All right, guys, well, welcome to this pharmacology drug class review on the drug category anti-diabetic drugs with a specific focus on the TZDs used in the management of type 2 diabetes. Now, this drug class initially created a lot of excitement as a potential target to the treatment of the underlying pathophysiology of type 2 diabetes. While it didn't pan out like the TZDs had hoped, the class history has been plagued with initial liver problems and then cardiovascular issues. Regardless, one agent still remains in the class, and we need to know what that is. All right, well, welcome. I'm Dr. Busti. Thanks for joining me on This Is Why, a show dedicated to helping all of us as healthcare professionals understand the why behind the decisions that we make, and that includes pharmacology and the drugs that we use. So when we understand why, how becomes easier. We understand mechanisms, therapeutic effects make sense, side effects make sense, monitoring parameters that lead to our counseling points. Now, as with all my drug class reviews, we cover core content. That means we need to hit the agents, indications, the net benefit. What is the pharmacology of the drug? How does it work? And then we start to get into some of that clinical application and those pearls that we need to think about, and then we'll wrap things up. All right, first is our agents. There's one. There's a lot that have come and gone throughout the years. As I mentioned early on, there was some liver issues. That agent's gone. Rosiglitazone is now gone, but still historically relevant, and I'll try to blend it in from a historical context or perspective. Okay, but Pioglitazone is the main agent that is still available and can be used. Now, moving on to indications and uses. Okay, so this drug class is used obviously for type 2 diabetes, but Pioglitazone in particular can also be helpful in patients with MASH, which is that metabolic dysfunction associated with steatohepatitis. Okay, and that's basically the newer term or whatever as it evolves. The point of the matter is there's fat in the liver and there's this metabolic derangement and dysfunction that occurs as a result of this. And we don't want to ignore that because left untreated over time not only worsens the metabolic demands, but dysfunction, but also can lead to liver problems. Okay, now we're going to hit and move into our net benefit. Why would you pick this drug class? Unfortunately, this class is plagued so much with problems with weight gain, fluid accumulation, some risk of exacerbation of heart failure that there's really not much one. So I'm not trying to beat around the bush with it. It does lower the A1C by 1 to 1.5%, but I have found that it's really not that beneficial. So when you see somebody on it, it's probably for some other augmented activity, or they've been established on it and they're doing fine with it, so no one really wants to mess with it. Just being honest, okay? All right, now we're going to kind of migrate into that pharmacology. What is the mechanism of action? And then we'll start to transition to where it fits in other treatments. Okay, so it works by decreasing insulin resistance, and that's where the excitement was. So this is a PPAR-γ agonist. That's your proliferator activated receptor gamma agonist. And so it turns on, regulates genes that influence glucose metabolism and homeostasis. So that's exciting. It literally thought we were going to treat the underlying problem. And so there was a lot of anticipation that this drug class, especially this was before some of the evolution of the other non-secretagogue, non-insulin drug classes that we are seeing more used today. So this was exciting, right? This allowed glucose and insulin to get into that cell more effectively, but it just didn't translate into the overall control that we were looking and needed for these patients, especially when you put it as the evolution of the side effects started to occur. Okay, so now we're going to move into our clinical knowledge application, because you are going to, this drug is still available. It's still an option. You still need to put it in the right place, okay? So I put together some tables. Those are available for you at thisiswhy.health. With that link to this episode is available in the description of the either podcast or on YouTube that you're watching. so that you can access these tables. But at a high level, the general treatment strategy of diabetes for type 1 is predominantly insulin, obviously, plus or minus pramlintide. Pramlintide can be used for type 2 as well. But type 2, you have your medical nutrition therapy, your exercise, and then that first bullet, which is monotherapy or combination therapy with a non-insulin based therapy. Well, that TZDs would fit right there, right? But by themselves, they're not going to get most people to goal. Okay, most people are not, unless their A1C already is close to 7. All right, remember you get about 1, maybe 1.5%. Okay, so if you use non-insulin-based therapies, then you start thinking about, well, there's 2 other subcategories. There's the secretagogues that increase the release of insulin, cause weight gain, potential risk of hypoglycemia, and then there's the non-secretagogue table for non-insulin agents, and that's where the TZDs fit, down here at the base, the bottom here. And so I put them in the context of other non-secretagogue, non-insulin-based drug therapy options, and you can see that really there's only one drug. And so where do you see the weight of drugs in that right column? You see it in the SGLT2 inhibitors, you see it in the GLP-1 agonists, and you see it in the DPP-4s. That's, I mean, these are drugs that are going to facilitate low risk for hypoglycemia, low risk for weight gain or weight loss, and can treat other comorbidities at the same time. Now, they're not benign drugs either. They have issues, just like TZDs have issues. But I just wanted you to see that in comparison. That makes us move on to the last table that I always provide in this series on anti-diabetic drugs, which is what medical conditions would I consider TZDs and other drugs, and what medical conditions or comorbidities would I avoid drugs and drug classes. And so I put it in the context of other drug classes as well here. So on the far left, we have our medical conditions like obesity, dyslipidemia, CKD, heart failure, right? And so where would we consider to use TZDs? That column shows none, because there really isn't any, right? That's specific to a comorbidity where you would purposely try to use them to help. So it's not helpful to pretty much anything. You're just going to help diabetes. Maybe MASH, right? To be fair, MASH is not listed here. So maybe that's, in fairness, we could do that, okay? But it's small, okay? Where do we avoid it? So you see TZDs here, plus or minus for dyslipidemia. There have been some case reports of weird things happening with the HDL and that's why that's there. Heart failure, avoid TZDs. Coronary artery disease, avoid. Well, I mean, the majority of patients with type 2 diabetes have these. That's why you don't see it. And so the evolution and understanding of these comorbidities has created problems. How about risk of osteoporosis leading to fractures? Yes, that's listed there. So maybe MASH and type 2 diabetes, those are your 2 main things, right? So metabolic dysfunction associated with steatohepatitis. There's some improvement in insulin resistance and fibrosis. Again, excess fatty acids, insulin-resistant states create some of the irritation, inflammation of the hepatocytes that cause more problems, eventually scarring, right, that leads to dysfunction. Prediabetes in patients also with a history of stroke. This has been something where these have been able to maybe be a place for Pioglitazone. TZDs are largely contraindicated, and this is huge from a board exam clinical perspective. Patients with New York Heart Functional Classification 3 and 4 have been known to be worsened or exacerbated with the use of TZDs, and more concerningly, even Rosiglitazone, which is why it's gone. We don't ignore it for Pioglitazone. It's just obviously not the same degree and concern as Rosiglitazone. But TZDs cause fluid retention, and that's part of the problem. They dilute the hemoglobin hematocrit, cause a dilutional anemia, but they also can worsen this. So this may be due to some regulation of maybe sodium reabsorption by PPAR-γ in the collecting ducts. That's the thought behind that. All right, so when we increase plasma volume, we can worsen the underlying heart failure, especially when these patients already have risk factors for heart failure if they haven't already, okay? From a geriatric standpoint, special populations, that, that pioglitazone is potentially inappropriate in patients over the age of 65, especially if they have underlying heart failure, okay, where as we get older, comorbidities evolve, they become more established. That's not surprising. And then lastly, that weight gain issue that does show up, okay? This is not primarily fat. It's predominantly going to be more related to that fluid issues. Now, I do want to take a moment here and talk about a study, integrate some evidence. So, we've been beating up TZDs, right? Not giving it a very positive bend here. It's my bias, my assessment of the literature. It's also what I see in real world, so I think there's some validity there. However, the proactive trial was published and studied with pioglitazone, okay? And that was published back in the Lancet back in 2005. And it was a pretty well-designed clinical trial with a large sample size of over 5,000 patients. And in there was a benefit and reduced risk for all-cause mortality, non-fatal MI, non-fatal strokes, and patients with diabetes and high risk for cardiovascular disease. So, I mean, that has some relevance. So there's an evidence-based perspective that goes back to that, value, the net reason why I might use it. However, in that same study, they will also show that patients needed more medication. So that's where the fluid volume problems come. So now you treat one thing, but now you're gaining more meds, and those lead to more side effects. And so then in the real world, not in clinical trial world, what is the overall net benefit? And it's, again, it's hard. But I wanted to be fair and talk about the proactive trial because it was a big, pretty landmark study back in 2005. Now, hematologic effects, remember that dilutional effect can lower the hemoglobin hematocrit. So when you start somebody on there, you want a baseline, and then you periodically monitor thereafter. Macular edema maybe causes maybe a little bit of blurred vision, can affect the visual acuity a little bit. So you may need to refer someone to like an ophthalmologist if that does show up. Unfortunately, there's been some signals or concerns about potential bladder cancer that showed up in meta-analysis and on observational data. This tends to occur with chronic use and cumulative doses, especially in patients who, from a European ethnicity, are Caucasian and prior history of bladder cancer. So that would be one of those another strikes against it that make it hard, to justify when you have all these things. Fractures, we saw that also with the SGLT2 inhibitors. That was on that table that I provided you. Obviously, it's going to be a little bit more in patients with chronic use, older age, patients who have difficulty seeing why because they can fall more easily and then find themselves in difficult scenarios. So don't forget that. And then the drug interaction, this pioglitazone is goes through cytochrome P450. And so you have to be careful with the use of drugs like Gemfibrozil, which is a strong inhibitor of phase 1 metabolic pathway 2C8. And so that could raise the concentrations, obviously, in the body. From a monitoring standpoint, that CBC gives you that hemoglobin hematocrit to allow you to understand and monitor that dilutional effect on it. If you have strong concerns about fluid overload, checking a pro-BNP or a BNP can be helpful because of that accumulation of fluid. And then, of course, you want baseline A1C, check it 3 to 6 months, make sure they get their goal. Liver function tests or liver enzymes, remember that's a black cloud that hangs over the entire class, really low risk compared to the older agents that are now gone. And then physical findings of edema, like that lower extremity edema, if they have vision changes, that macular edema, those are things that kind of guide us. Okay, guys, wrapping up TZDs, we have pioglitazone, very limited use, mainly type 2 diabetes, MASH maybe. Right, it works on that PPAR-γ as an agonist to regulate genes for glucose metabolism and homeostasis. Sounds fantastic, right? But is associated with edema, weight gain, overall low risk of hypoglycemia, There is some evidence with Pioglitazone, that proactive trial, but you got to avoid it in patients with New York Heart Functional Class 3 and 4 heart failure. Please, please know that. Okay, so I hope you found this to be helpful in the context of managing type 2 diabetes, in the context of other drugs, pros, cons, issues. Try to be fair, but compared to other agents now on the market, obviously it's fallen down in its list of priorities of being used. So I hope you found it to be useful. I'm Dr. Busti. Please never stop investing in your knowledge, understanding why you do what you do. It makes sense of then how to take care of patients better and more effectively. Looking for things even when they come in. If you're not the one who started it, it makes sense. It helps you to identify the underlying cause so you can treat that underlying problem. I'm Dr. Busti. We'll see you next time. Take care, everyone.